once again, greetings everyone. Welcome to the 122nd session of the online Optom learning series. And for today's session, we have with us Dr. Elise Kramer. Dr. Kramer is a residency trained optometrist in Miami, Florida. She specializes in ocular surface disease as well as regular and specialty contact lens fittings. She achieved her doctorate degree in optometry from the University in Montreal in 2012, where she received a grant from scholarship programs of the Queensback Ministry of Education for short-term university outside Quebec. She is also the recipient of various scholarship awards based on her academic performance as well. She is also involved and she participated in the humanitarian mission project in Morocco, where she helped hundreds of underprivileged people, if I may put it that way, by giving them free eye examinations and glasses, providing eye health screenings in other words. She has a couple of fellowships into her credit. She is a fellow of the Scleral Lens Education Society. She is also the Public Education Chair for Scleral Lens Education Society, a member of the American Optometric Association, a member of the British Contact Lens Association, and also a member of the International Association of Contact Lens Educators. She also has a fellowship of the American Academy of Optometry. She's been involved into teaching contact lenses and ocular surface disease, also done her residency in ocular surface disease, in ocular disease to be more precise, and various publications in the field of contact lenses. And if I'm not mistaken, I was just reading about the recent publication on the impact of scleral lens on IOP, right, Dr. Kramer, which recently was accepted and published. So very knowledgeable person, I would say, in the field of contact lenses and ocular health, surface ocular disease. And today, Dr. Kramer is going to talk to us about grand rounds in anterior segment, taking us through some cases and what are the management options, what are the signs and symptoms do we need to look for. So welcome, Dr. Kramer, onto our platform. Thank you so much. I know it's a Sunday morning for you at your place. Thank you so much for giving us your time.
No, thank you for having me. It's an honor to be able to give this course. And it's actually, I'm happy that there's a lot of students because it's a really good course for students. The way it works is basically, I'm going to present various cases, and the way I'm presenting them, you guys won't really know the answer right away. And so you'll have to kind of think about it and the different diagnoses. And this is a great practice for students and also people in clinic, but it's really great for students because it kind of forces you to go through a lot of your knowledge and studies in order to come up with the right answer, which is essentially what we do in clinic every day. So these are my disclosures. Let's start with the first case. So this is a 63-year-old white female. She came in for a comprehensive eye exam. She was seeing 20/25 in both eyes. She has posterior, she has IOL, so intraocular lenses in both eyes, not using any drops, no family history. She's also got some diabetes. She's taking metformin and Zetia, both for diabetes type 2. And she complains, this is her chief complaint, she complains of itching, burning, watery eyes. So then we look at her eyelids, and this is what we find. Okay. So I guess you can start the first poll here, Gruden. So what is the differential? So this is a differential diagnosis, right? Allergic conjunctivitis, blepharitis, ocular rosacea, and bacterial conjunctivitis. Great. So a lot of people think it's blepharitis and Meibomian gland dysfunction. Some people think it's allergic conjunctivitis or bacterial conjunctivitis, and all of these are similar, you know. But one thing that we do here in clinic is in-office gland expression. And you can do that using your finger. You can do that using these devices that actually express the glands. I personally use the fingers. I find it's a little bit, easier to do. But if you have the Meibomian gland, device in your office, you can use that. The reason I don't like it as much is because it doesn't express the glands as well as the finger does, whereas the finger really, really gets the oil out. So how do we diagnose, what it is? How do we differentiate between those differential diagnoses? Every time you see a patient with those symptoms, all those differentials should come up, but eventually what you're going to do in clinic is you're going to use different devices to basically figure out what it is that you have. So one thing that I like to do on my patients that complain of itching or burning, they might have some, Meibomian gland kind of, when I express it, some pasty oil comes out. I like to do meibography. There's various devices that we have. You can see here on the top right, this is called transillumination. That was the first way that it was ever done before meibomiography existed. They would just put a transilluminator in the eyelid and you could visualize the Meibomian glands there. But, there's different devices. There's the Oculus. We have the MyBox, which you can see on the bottom left, Liposcan. So these are different devices that, again, allow you to visualize the Meibomian glands. What we use is infrared light, and you can visualize them like you can see in the top right. And on the bottom, you can see the gland dropout there in this video. And gland dropout is what essentially can cause Meibomian gland dysfunction. And that is what can cause, symptoms of dryness. So another really important study is the TFOS-DO study. This is probably the best summary that exists right now about dry eye, the pathophysiology, the epidemiology, the treatments available, management, everything is in this study. And what I like about, and there's a summary that the TFOS-DOs is extremely long. But there is a really good summary that I recommend you read. Basically, it goes over the two different types of dry eye, which is aqueous deficient and evaporative. And then it explains both. And obviously, dry eye can be a combination of those two things. But I think this is a really great study. This is one of the tables from that, or flow charts from that study. And basically, what we know now about dry eye disease is that it's a problem with homeostasis on the ocular surface. And again, it's just because there are not enough tears, or because the quality of the tears is not good enough, or it's mixed. As you can see on the bottom here, a large part of it is evaporative. Most of the time it's evaporative, but obviously there's aqueous deficient patients as well. And there's a number of patients that are mixed. But basically, regardless of what type of dry eye it is, the management, what you're trying to do is restore that homeostasis. So if you go through this chart and you use this, you can actually figure out what type of dry eye your patient has. Again, the management and treatment is going to be very different. So it's important to understand, do they have symptoms or not? If they have symptoms, what are they? And what kind of clinical signs do you have? And that's where meibomiography comes in. And this is, again, a very important image showing the inflammation on the ocular surface. You can see all those inflammatory mediators in this cycle. Again, it's a disruption in tear osmolarity. There's high evaporation that's going to be part of, regardless of whether you have evaporative dry eye or aqueous deficient dry eye, you're not having enough tears on the ocular surface. And it's either because you're not producing enough tears because you have aqueous deficient dry eye, or because they're evaporating too quickly. And regardless of what it is, you have a tear, again, the tear osmolarity is disrupted, and the homeostasis is disrupted. And what you're trying to do, again, with management and treatment is restore that homeostasis. So you can see in this image here, the different origins on the side here, on the left side, you can see what causes aqueous deficient dry eye. You've got just Sjogren syndrome or other ocular surface. And on the right, Meibomian gland dysfunction is probably one of the main reasons why people have evaporative dry eye. So what is evaporative dry eye? Evaporative dry eye is eyelid related. Okay, it's caused by Meibomian gland dysfunction. It can also be blink related. So I'm finding so many people are working from home these days because of the pandemic, and they come in complaining of itching, watering, tearing eyes, right? And they don't necessarily have Meibomian gland dysfunction, but they're just not blinking enough. And it's very interesting because you're supposed to blink about 12 to 15 minutes normally. And what blinking does is it releases that oil on the ocular surface. And what the oil does is, or the lipid layer, prevents the tears from evaporating. But it's kind of like a windshield wiper. But if you're not blinking, and really when you're in front of a screen and extremely concentrated, you might be blinking just 2 to 3 times a minute. And then the ocular surface can dry out and you can have evaporative dry eye without even having Meibomian gland dysfunction. Obviously, the worst combination would be having Meibomian gland dysfunction and having just a poor blink reflex. Let's say people who have Meibomian gland dysfunction and are working on the computer, those people will have a lot of evaporation. And it could be ocular surface related. So it could be related to mucin. It could also be related to a contact lens. Now, there are a lot of contact lenses on the market. A lot of you might work with contact lenses. Contact lenses are great. And I believe that any patient, 99% of patients can wear contact lenses. But the truth is that a contact lens is a foreign body, okay? And if the ocular surface is not optimized for a contact lens, or it's not optimized, period, a contact lens might induce more evaporation. So the ocular surface really has to be optimized before introducing a foreign body. That's really important. So is evaporative dry eye age-related? We know that 78% to 86% of all dry eye disease is evaporative, that the symptoms are itching, burning, watering, redness, thickened meibum, and they can have also SPK. They might have a lower tear film breakup time. They might have meibum in their Meibomian glands. And basically what the meibum in the Meibomian gland does is it decreases the amount of terpenoids, which increases the amount of proteins, which then leads to thicker secretions, and that leads to plugging of the glands. And when the glands are plugged, then the oil doesn't come out. And if the oil doesn't come out, then you don't have that protective layer over your tears, and the tears evaporate. So that's basically how Meibomian gland dysfunction works. And obviously, we talk about biofilm, so there's bacteria on the surface as well. And obviously, if you have higher osmolarity, you're going to have more of these bacteria, more hyperosmolarity, more inflammation, more evaporation. So all of this leads to greater evaporation and greater dryness on the surface. The problem is that a lot of people are not treating this condition. I treat it, and I'm sure a lot of you do, but a lot of our practitioners don't. They might just give drops and send the patient home. So the question is, why don't people look at Meibomian glands? Is lack of time. It's not sight threatening. So a lot of the time optometrists are focused on the bigger issues. So optic nerve, is there any retinal issues? Especially for this patient, she had diabetes. So that's something that might kind of take over. Okay, she has diabetes, so we have to do a dilated retinal exam and check the retina, make sure there's no hemorrhages. Yes, that's important, but don't forget about the front of the eye. So Meibomian gland dysfunction is not sight threatening, so it might not be at the top priority for a lot of eye doctors or eye practitioners. And patients might not follow what we say. We say, okay, you have meibomian gland dysfunction, you need to do X, Y, Z treatments, and they might not do it. So, that's frustrating for both us and them, because there are a lot of treatments and a lot of steps in order to try to make this better. Another question that some practitioners might have is this profitable? Does it generate revenue for the practice? And it really does if you do it. So I think, it definitely does. But this is a question that people ask themselves, and maybe that's why they aren't looking at meibomian glands. So what is the treatment and management? So definitely you want to start with an at-home treatment. Education is very important. So you definitely want to explain to patients the nature of the condition. I like to show patients their glands. I have meibography in my offices, and I always show them their glands to show them what's going on. It's kind of like when you go to the dentist and they show you the x-ray and they show you where the issue is and they show you why you need a root canal or why you have to get a cavity removed. It's the same thing with meibography. I really, really like showing patients. And almost all the time, we start an at-home therapy. So at-home therapy would be omega-3, like you see on the top right. Eye drops are important. That helps kind of hydrate the ocular surface and prevent inflammation. And then you have lid hygiene is very important, getting rid of that biofilm on the eyelashes, on the eyelids, and the warm compress. I think the warm compress is an excellent treatment. The only problem is it really has to be done twice a day, and it has to be done for at least 5 to 10 minutes twice a day. So it's a lot of work for the patient, and it can change their lifestyle, but it works. And it works only if it's done. But it does work really well. So warm compress is an excellent treatment.
Stem from sight.
Sorry about that. So other treatments that we have in the office would be that are possible: IPL, tear care, and of course LipiFlow. So these are all treatments that are working on improving the health of the meibomian glands. What they do, especially tear care and LipiFlow, is that they heat up the upper and lower eyelids where the glands are, and that allows all that blockage to come out. So all those very thick secretions to come out, and that restores the function of the glands, because instead of producing solid meibum, what they're going to start producing is that liquid meibum, the one that we need. And it also prevents loss of meibomian glands, and some studies show that it also helps regenerate the glands that have already been lost. So it's a really great treatment. Okay. So another issue that you might encounter is this, and this often comes along with, meibomian gland dysfunction. Okay, so this is something that you need to check for all the time. So let's start the second. Poll. What is this? And I'll go back to the image so you can see here. I think I can.
Yeah.
Okay, so a little bit divided this time. So you can see, false lashes, something that you want to think about. Rosacea for sure. But Demodex is, I agree. I think that this is something, most people said Demodex here, and that's really something you want to look for in these patients. So the answer is Demodex again. So how do we look for Demodex? Basically you come up with a clinical suspicion. So clinical suspicion obviously comes from examining the patient. You look at the eyelids and you see that sleeving at the base of the lashes. You can see it under the slit lamp. Obviously the real way of diagnosing it is under a microscope. Not everyone has this in their practice, nor is it standard of care, but that's really the way to diagnose this. But you can really see it if you look at your slit lamp and you see that sleeving. A lot of the time, the collarettes, that's gonna be an anterior blepharitis. They're gonna be a little bit more like in the middle of the eyelash, and these ones are really at the base of the eyelash, and they're a lot bigger, and you'll see a lot of inflammation at the base of the lash, and that will confirm basically that you have Demodex. So the treatment for Demodex is tea tree oil. Okay, tea tree oil is terpenin for all is toxic to Demodex. Another thing is if you just treat anterior blepharitis, so let's say with hypochlorous acid, or those sprays and wipes that are made for cleaning eyelashes and anterior blepharitis, those also work with Demodex, but they work indirectly because Demodex feeds off of bacteria. So the more anterior blepharitis you have, the more Demodex you'll have. So if you get rid of the anterior blepharitis, you'll indirectly get rid of the Demodex. But the real way to eradicate the Demodex is by using tea tree oil. But it's definitely a comorbidity, and it can make it a lot worse. And it's pretty gross when you think about it, but it's really there, and it's there in a lot of older patients. All right, so let's go to a second case, the dry spell. So this is a 28-year-old white female. She presents for a comprehensive eye examination, and she's wearing contact lenses. Okay, she's wearing a brand that we have here in the US. It's called Vertex Sphere, and the power is -250, base curve 8.6, diameter 14.2. She's using a multi-purpose solution that we have here. It's called OptiFree Replenish. She replaces her lenses monthly, which is what she should be doing, and she doesn't sleep with them. She also has a history of thyroid cancer, and she had her thyroid gland removed. She complains that her lenses are just very uncomfortable. Okay, so evaluate her. The right eye a little bit less clear, but she's 20/20 in both eyes. Found an over-refraction on the right eye, so you can see she was wearing a 250. I found a 275. This is her refraction. You can see at the bottom, and you can see her topographies as well, our K readings. So let's do the poll. What is the next best option? Would you switch her to a more modern soft lens, a LASIK consult, switch to orthokeratology, or daily disposable contact lenses? So 100% right now. Oh, no, we have some people who want to switch to a more modern lens. It's true, the lens that she was wearing is not that modern. Orthokeratology is a great way to bypass daytime discomfort with contact lenses, and daily disposables is another great option. So let's see. A lot of you are saying no. Oh, some people say LASIK, but most of you agree that switching to daily disposable lens is probably the best idea in this case. Okay, so I flipped her eyelid. Okay, and this is what I found. So I think that whenever you're seeing a patient with contact lenses, even if they don't complain, you want to check the upper eyelid. There's so many things up there that you might not notice, and you could preemptively make clinical decisions just based on that. But certainly, if they're not tolerating their contact lenses, you want to check why. And flipping the eyelid is really, really important to do. So what is a non-candidate for LASIK? So some people said, well, maybe one or two people said, let's refer for a LASIK consult. And just so you guys know, if you work with, ophthalmologists out there, what is a reason not to send out for LASIK? Basically here, Fuchs endothelial dystrophy, corneal epithelial membrane dystrophy. So any corneal dystrophies, retinal tears, we know that, having a LASIK procedure might increase the risk of a retinal tear or detachment. Here, they don't do it under people who are 21. Any autoimmune diseases, pregnancy, lactation, people who have unrealistic expectations. Severe dry eyes is definitely a contraindication, and significant blepharitis. So we just went over an entire case on blepharitis. If the patient has blepharitis, it should definitely be treated prior to doing surgery. So when you do refer a patient for LASIK, there are some things you need to do. You need to do a dilated exam, obviously. You need to do a corneal topography, a refraction. A lot of surgeons prefer if you do like a cycloplegic refraction. But anyway, this is all really important before LASIK. So she actually ended up doing LASIK. Basically, when you have a patient with giant papillary conjunctivitis, like we saw in our patient, you know, the contact lens options are limited. Yes, it would have been great to switch her to a daily contact lens. And I actually did switch her to a daily contact lens, but she still didn't tolerate it. Orthokeratology is not an ideal treatment to do in patients who have giant papillary conjunctivitis for obvious reasons. We know that the pressure of the eyelid pushes on the lens, which pushes on the eye. And if the eyelid is irregular because of giant papillary conjunctivitis, then it's just not going to work out. So this patient underwent LASIK, but then she came back like this. So let's go back to the poll here. What is the diagnosis in this case? So very divided. A lot of people think it's superior punctate keratitis. So she actually had DLK, diffuse lamellary keratitis, which is really bad luck if you think about it. You know, like she couldn't tolerate her contact lenses, and she had giant papillary conjunctivitis, went in for LASIK and came out with this. This is a really bad inflammation after LASIK. It's rare. It's not an infection, but basically what you have is inflammatory infiltrates underneath the corneal flap, and they call it sands of Sahara. And this is what it looks like. It happens about 1 to 2 days after refractive surgery. It resolves 5 to 8 days later if you treat it properly. And it happens to about 2 to 4% of patients undergoing LASIK. We don't exactly know why it happens. And if there's a corneal defect, like an abrasion, then that increases your chances by 24 times to have DLK. So definitely if you have a corneal defect or abrasion, it will increase your likelihood. So the symptoms are pain, foreign body sensation, photophobia, light sensitivity, blurry vision, which is not exactly what you would expect after LASIK. And these are just the different stages. Obviously, stage 4 is really, really serious. We're talking about corneal melting. But before that, you know, it's definitely manageable because it's just beginning. So the treatment is a steroid, antibiotic, artificial tears, also bandage contact lens. So this is what we did for our patient. We gave her a little bit of everything. And sometimes they have to irrigate underneath the flap and then reposition the flap and remove subepithelial infiltrates to minimize complications. So that was unfortunate, but she's doing really well today, and it's resolved. So that's good. And you know, she doesn't need contact lenses anymore. So, all right, so let's go to case number 3. Tip of the iceberg. This is a 30-year-old African-American female that presents for a LASIK consultation. This is her vision, and she's not using any drops. She never had surgery. She never had injury. And basically, this is her refraction. So you can see a high amount of astigmatism in both eyes, right? And so what I do, if I see an amount of astigmatism like that, in addition to doing a retinoscopy, I also always do a topography, always. And this is what we find on topography. So let's go ahead with the poll here. A lot of people are saying irregular astigmatism, pellucid marginal degeneration, but 50% of you think this is, or a bit less than 50% think it's keratoconus. Okay, so how do we decide what the right diagnosis is? There's various ways. So you can use the slit lamp. Okay, if your patient has keratoconus, you'll see something like on the right side. Okay, if the patient has a normal cornea, then you'll see on something like on the left, right? But other ways is you can look from the side, okay? And obviously if you see that cone shape or protrusion, then you're thinking keratoconus for sure. There's also a sign called Ritucci's sign. Basically, it's when you shadow or a kind of like a moon shape on the side of the face, okay? That will happen in keratoconus. So Ritucci's sign, that's what it looks like. There's another sign called Charlouet's oil droplet, and you'll see this when you do retinoscopy. You'll see it kind of looks like an oil drop when you're doing retinoscopy on a patient with keratoconus. And then, of course, the scissor reflex, which I'm sure you guys all know. This of course, is with retinoscopy. If you actually move that beam, you'll see kind of a scissor reflex. You will not see the typical, up, down, left, right, or with and against movement that you will see with regular retinoscopy. It will look like a scissor. Okay. Munson's sign is you ask the patient to look down, and what happens is that lower eyelid goes down significantly more than in a regular patient. So that's Munson's sign. Fleischer ring. So Fleischer ring is just, this is not the best quality image, but you can kind of see that the color change there. It's just basically iron deposits at the base of the cone. So that's another way of checking. And then Vogt striae, this is when you have folds in the cornea. So you'll see those on slit lamp examination. So let's go back to our patient. So we diagnosed her with keratoconus, and we fit her with scleral lenses. And you can see here, we got her to see 20/20 with these parameters. And this is obviously not the patient came in, remember, for a LASIK consultation. This is not a patient that you want to do LASIK on, obviously. And she did really, really well with scleral lenses. Okay, so that's our patient wearing the scleral lens. So you can see the lens there sitting at about 16 millimeters out on the conjunctiva. So what is a scleral lens? You guys know the difference between a scleral corneal lens or a corneal scleral lens. Basically, it depends on the diameter. A scleral lens rests entirely on the conjunctiva overlying the sclera. Today, they're made of very high decay materials like Boston XO, Menicon Z. I'm not sure what you guys have there. A corneal and corneal scleral lens, they either rest completely or partially on the cornea. The corneal sclera will have partially on the cornea and sclera, whereas the scleral lens is completely on the sclera. A scleral lens is divided into 3 different zones: the optic zone, transition zone, and the landing zone. So for those of you who fit lenses, this is what you need to know. Obviously, the optic zone is correcting the vision. The limbal zone is just slightly over the limbus, and the haptic or scleral landing zone is going right over the conjunctiva. This part is really important because that's what's going to determine the comfort of the lens and also the wearing time. Okay, so you can see here a lens with various different zones, and this is an 18 millimeter lens, so you can see very well demarcated zones here in this image. So how do we fit a scleral lens? Basically, you choose a diagnostic lens in your office with a diameter and design of your choice. You evaluate, you put it on the eye, you evaluate apical clearance, you evaluate limbal clearance, evaluate the scleral landing, and then to finalize the vision, you do an over refraction. Okay, when you put the lens on the eye, you want to make sure it's filled with preservative-free saline solution and also with fluorescein. Okay, and then what we do is we put that on the eye, and you know the thickness of the lens. The lens has a center thickness in this specific image of 0.35 millimeters, which is 350 microns, right? And so what you want to do is compare the thickness of that fluorescein layer to the thickness of the lens. So you can see that the fluorescein layer is about the same. So now you know that the fluorescein has a thickness of about 350 microns, right? So it's a 1-to-1 ratio. And that's pretty much what you're trying to get, something like that, maybe a little bit less. What you don't want to do is compare the fluorescein layer to the corneal thickness. And the reason is because the corneal thickness varies. It varies from one patient to the other. It varies from one eye to the other in the same patient. And even in this one eye, the thickness could be a lot greater, superior than inferior. And so it can definitely vary. And so you do not ever want to compare the fluorescein layer to the corneal thickness, but always to the lens thickness, which is constant, and it doesn't change, right? We take into account scleral asymmetry. We know that the sclera is not symmetrical. It actually has the shape of a hyperbolic paraboloid, kind of like this chip here. And we discovered that based on impressions that we were taking of the eye. And so this has to be taken into consideration when we're fitting scleral lenses, right? So we know that there is scleral ptericity, and we take that into consideration. We have devices now that can measure that. And we also have the ability to do impressions like you see in the top video. And those are modern impressions, much different from the one that you saw in that video. But it's just very interesting that over more like 75 years, we're doing the same thing as we were doing back then. So scleral ptericity is real. And what are some surgical options for keratoconus? Well, they do increase the amount of astigmatism or also myopia. Cross-linking is a really great procedure because what it does, and this is riboflavin, what the combination of riboflavin and UV light does is it strengthens and it creates cross links inside the cornea. Okay, and that strengthens the cornea and prevents it from getting worse. So highly recommend this type of procedure for your patients with keratoconus. That will prevent the condition from getting worse. Sometimes it makes the vision better as well, not always, but it does prevent it from getting worse. And then obviously, for corneas that are just very, very scarred, then you might have to do something like a penetrating keratoplasty. Obviously, we don't do this type of work, but we work with a lot of surgeons that do it. And I'm sure a lot of people do it out there as well. So we try to avoid the need for a corneal transplant by fitting them with contact lenses, by doing other, sending them for other procedures, but this is like a last resort. So this one's called It's Growing on Me. It's a 45-year-old Hispanic male who presents for a comprehensive eye exam. Vision is 20/50 in the right eye and 20/25 in the left, not using any drops, never had surgery, has high blood pressure, and complains of a growth on the corner of the eye. So you can look and see there what it is. So let's go ahead with the last poll. What do you think that this is?
So almost 85% of them think it's pterygium, and then a couple of them think it's penguicula also. So
how do we know what it is? I think the OCT is anterior segment OCT is a great device because what it can show us is what layer, what layer this is in. Sometimes you want to know, is this a conjunctival intraepithelial neoplasia, which is going to be inside the epithelium? And you can see that on the bottom image there. You can see that the irregularity is inside the epithelium. Whereas on the top image, you see that it's really on top, right? It's on top of the cornea. And so that's not a CIN or conjunctival intraepithelial neoplasia. That's going to be a pinguecula. It's going to be CIN or OSSN, which is obviously malignant. Then you want to have them sent for an excisional biopsy. What they do is impression cytology, and they look at it. But also the clinical appearance sometimes can give you a lot of indication of whether it's cancerous or not. And so I think that's really what we try to do here. I live in Florida. There's a lot of sun here, and UV light can definitely cause, cancer on the front surface of the eye. CIN is very, very common, and pingueculas and pterygiums are also very common. So you definitely want to be able to differentiate between those two things. If you see leukoplakia, so you can see that those white deposits there, that's almost going to tell you that this patient has a malignant lesion, okay? So if you see leukoplakia, we say it's pathognomonic for CIN, okay? And CIN, again, is conjunctival intraepithelial neoplasia, which is a malignant lesion. So if you do see those white deposits, you really want to send them for further evaluation, okay? That's really important. And you can see here these large feeder vessels, blood vessels, which you won't see in a pinguecula, okay? So a pterygium is something that basically I think has a lot, and studies show has a lot to do with UV going on the front surface of the eye, just bouncing off the nose and causing fibrovascular growth on the front surface of the eye. And obviously what it can do is it can cause, irritation. It can become inflamed, and it can cause vision changes, right? So it definitely has to do, they call it the surfer's eye, because a lot of surfers will have this problem. Basically, the more UV light you're exposed to, the more likely you are to have this type of fibrovascular growth. So you can, if it is affecting the vision, it can be removed. What they use is mitomycin and 5-FU, and that helps prevent it from recurring, because it does recur. And a lot of the time they do a flap graft. That's kind of the gold standard. Okay. So what I do to check, is this really, changing the vision, is I'll do a topography. And remember, this patient had 20/50 in the right eye, but you want to see a topography. How much astigmatism induced do you need to have for it to be like, okay, I need to send this patient for a referral? And my rule is usually if I see more than 3 diopters of astigmatism induced, then I send them to an ophthalmologist. So that's pretty much all I have for today. I'm here for questions, obviously, if you have any. But thank you for your attention. Thank you for being here, and I hope you enjoyed it.
Great. So thank you, Dr. Kramer, for that wonderful cases, 4 cases which we went through, totally different from each other, but yet connected, because as we will see them very often as primary eye care practice, right? So in that sense, they are very common cases which we will see them in our practices, and it's really important to know how to go about, diagnosing them and what are the available options which you can suggest to your patients. And I think we are going back to history, I feel, because the impression technology, I think, just came in 3 years, 4 years back, which, right? With the eye.
It's very interesting. It's very interesting that we're doing the same thing that they were doing back then. Obviously our technology is a lot better now. It's more advanced, but it's just really, really interesting.
Yeah. And just that question connecting to that. So I'm assuming that you are doing eye print in your office, or?
Yeah, I do eye print. It's a great technology. It's not the only one I use, but it's really, really great for a lot of patients. So there is a question here. It says, how do you differentiate a blepharitis from a meibomitis in a slit lamp examination?
Yeah.
Okay, so I think that one of the key things here is that blepharitis is a lot more common, right, than meibomitis. So yes, it's possible to have an infected meibomian gland, but what you'll see in affected meibomian gland is you'll see kind of like an accumulation or a lesion in that one area, okay? And what you might see is just one gland that's blocked with associated inflammation, right? And some patients can have both at the same time, right? They can have blepharitis and they can have meibomitis at the same time. So how do you and basically the treatment is very similar. The only other thing that you have to take into consideration in meibomitis is that it is infectious. So you have to give them an antibiotic. And the only type of antibiotic that really works in this case, unless it's draining, is an oral antibiotic. So again, what you want to do is just check for a local blockage with kind of an associated lesion in that area. If you don't see that and it's just diffuse kind of meibomian gland loss, then it's going to be blepharitis only.
And let's look at another question. We do understand that pterygium will induce some amount of astigmatism. What could be your treatment options when it comes to these patient post removal? Would you be prescribing them with scleral lenses?
Yeah, that's a great question. So if you talk about a cylinder-induced post-pterygium surgery, certainly we're talking about irregular astigmatism. Obviously, I always try, my order is trying to correct it with glasses, obviously seeing what the patient wants, if they want contact lenses. If I can get them to 20/20 and they're happy with soft contact lenses, I'll do it. You know what I mean? But if the astigmatism is too irregular and I'm just not able to get them to 20/20, then obviously scleral lenses would work really, really well in this condition. The only thing that you have to take into consideration is that the scleral lens will be landing right over that area where you had the pterygium removed. And so you really have to be able to customize your landing zone. And that's where an impression might work really well, or advanced technology, quadrant specific scleral lens technology.
Yeah, you don't want to rub against the pterygium area because it might aggravate the condition. Would that be also an important thing to look at?
Yeah, so you definitely don't want to make it worse. And so you can either notch your lens, or you can just customize the landing zone right in that area, or do an impression of the eye. So those are really the options you have to optimize. But scleral lenses would be a great option for induced cylinder in these cases.
Great. I think notching was something which Dr. Dadi Fadel also talked about when she did a session with that on scleral lens fitting. She's a fan of notching the lens in pterygium penguingula cases, right?
Yeah, definitely.
Okay. And in your experience, is there any relationship between the amount of astigmatism and the time of pterygium removal? So if you remove pterygium earlier, it's low astig, something like that.
Well, I think it makes sense. Like the bigger the pterygium is, right, the more tissue has to be removed and the more induced astigmatism you're going to have. In theory, it might not happen like that. It's very unpredictable. It's not a refractive surgery. It's not like cataract surgery or LASIK where you can predict what the person is going to see after. So you're kind of like, the goal is to remove the pterygium, and especially if it's not a pterygium, if it's like a CIN, you really want to remove all of it. And it's really hard, but I would think that the more tissue you have to remove, the more astigmatism that might induce. So the sooner you treat it, the better, obviously,
Okay, great. And I think would it also be related to the type of surgery the surgeon prefers to do, because we know they have the graft,
right?
Type.
Yeah, I don't know. That's kind of out of the scope of what I do. Yeah. But certainly they must try to limit the amount of astigmatism induced, and obviously they want a good cosmetic appearance. Yes. So, yeah.
Okay, great. And in VKC patients, how to manage the limbal thickening area? Have you come across any such?
No, I haven't seen that. But you can like I explained in scleral lenses, you have 3 different zones: the optic zone, the limbal zone, transition zone, and the scleral zone. So if you are working with the scleral lens in these patients, then you can modify the zone. I'm not sure if that's what the question is asking for, or if just the limbal thickening in the eye. I'm not sure.
I think it's mostly related to the VKC patients, but then probably we'll have to get back to the person, and probably if he can elaborate more, you could probably
definitely.
Let's see, which lenses have more complications as your experience, mini sclerals or scleral lenses in case of?
It really depends. I would say the larger the scleral lens, the more you're going to interact with the toric, surface. So if you don't modify your lens as a result, then you'll have more complications, right? But if you do know how to modify your lens or customize it to fit the shape of the eye really well, you might have more complications in a mini scleral, because mini sclerals, sometimes they sit right near the limbus, and that could be very irritating for patients. So I would say if you know how to manage and customize your scleral lens landing zones, then you'll probably have more complications in a smaller lens.
Okay, great. And a couple of more questions here, Dr. Kramer. I saw a contact lens induced warpage in one of the questions on the polls. How common is it to see which patients with contact lens induced warpage?
Yeah, so obviously if you're, I'm not sure if you're talking about soft lenses or hard lenses. Obviously, if you're wearing rigid gas permeable lenses that are resting on the cornea, that can definitely cause warpage, especially if it's not a lens that's fitting properly. But I've seen warpage with soft lenses. I've seen patients with daily disposable toric lens that induced warpage. It's very interesting. Is it common to see it? It can be, but it's not. I wouldn't say it's extremely common. But I think that if you're trying, you're refracting a patient, it's fluctuating, and you're not really able to help them see well with the soft lens, do a topography and you'll see it there. You'll see the warpage there for sure.
That's right. Yeah. And how would you treat dry eye in Sjogren's syndrome patient? I'm sure you will say scleral lenses would be the best option.
Well, scleral lenses are a great option, but remember, going back to the TFOS-DO study, I was talking about aqueous deficient dry eye, and Sjogren's syndrome is one of the main causes of that. Okay, so what you want to do in these patients is that that they're not producing enough tears, right? So you want to help with that as well. So in addition to scleral lenses, I would definitely recommend cyclosporin, lifitegast in these patients. Those are two prescription medications we have available here. Artificial tears, we also have autologous serum tears or growth factor tears that we use here, and those help regenerate the ocular surface. So those are two things that I would do. That's kind of a different treatment management than for evaporative dry eye. But I think those patients benefit a lot from those eye drops, as well as scleral lenses.
Okay. And just to continue this question in terms of scleral lens usage for dry eye management versus scleral lens usage for corneal ectasia or corneal disorders, is there anything different you do in terms of fitting scleral lenses between these two?
Yeah, that's a really good question. In a patient that has, ocular surface disease, I usually aim for a bigger lens. Like I have a patient with severe dry eye that is in a 20 millimeter lens. I have other patients with, Sjogren's syndrome that are wearing 18, 19 millimeter lens. So I like to cover as much of the ocular surface as I can. Whereas in a patient with corneal ectasia, you could even use a mini scleral lens, right? But what you're trying to do is neutralize the corneal ectasia. And you can do that with a relatively smaller scleral lens. Whereas what you're trying to do in ocular surface disease is you're trying to restore and regenerate the ocular surface. So the bigger, the better in those cases.
All right, great. And any changes in the solution in the bowl, you make it different, or is the same as using the same for both the patients?
Oh yeah, I mean, well, what you can do also in ocular surface disease patients is actually put some preservative-free artificial tears. You can put some preservative-free antibiotics. As long as it's preservative-free, it can go in there. Some patients fill their lenses with autologous serum tears as well. So there's a lot of options. But again, as long as it's preservative free, it doesn't matter. But yeah, for those patients with ocular surface, you might want to do more of a cocktail of drops and saline rather than just saline alone, like you would do in a corneal ectasia or irregular astigmatism patient.
Okay, great. And let's look at one last question before we this thing for today. For presbyopic patient, is it possible for them to wear near prescription glasses over the scleral lenses?
Yeah.
Or you probably do a multifocal scleral lens fitting?
Well, I do whatever the patient wants, right? So there's 3 options for correcting near vision. And I think this is such a good question because presbyopia is affecting 100% of our patients, right? After the age of 40. And even those who have keratoconus are going to have presbyopia, right? And even those who have Sjogren's syndrome have presbyopia. So it's a really good question because this is something that we are going to need to address when our patients are over 40 years old. So there's 3 ways to do it. One is to have them, and probably the most simple way is like Anissa says in this question, is to use reading glasses over the scleral lenses. So you correct the scleral lenses for distance and you put reading glasses over. And obviously those could be just for reading. They could be progressive with obviously 0 in the distance. So those are the 2 options there. Another option is monovision. So 1 eye for distance, 1 eye for near. Obviously use the dominant eye for distance, the non-dominant eye for near. And then multifocal. So as you mentioned, Fakhruddin, there's a lot of manufacturers that offer multifocal technology in their scleral lenses. This works really well. It's a little bit more, I charge a little bit more for that to the patient. So it really depends also on their budget, you know. But this is a great option and it works really well for a lot of patients. So I think just offering your patients 1 or all of those 3 options is really good.
That's nice. Okay. And just one last question which just popped up. Any reference guide which you want us to refer in terms of learning more about eye print or, you know, this customized scleral lens? Any reference? No.
Yeah. So there, I think their iPrint Pro website is really good. There's some videos there. You can also go on YouTube and see videos of iPrint. There's some really great videos that actually show you how the impression is done with real patients. It's a lot like ocular prosthesis, right? I'm sure you guys have that. So people who design prosthetic eyes, they use a lot of the same technology. And then another technology, obviously, that I think is really great is the profilometry or scleral topography. And so you can check out the eaglet eye, the CSP by Pentacam, and also the SMAP 3D by Visionary Optics. Those 3 technologies are really great for measuring, you know, beyond the limbus, the topography. And that it gives us important information about sagittal height of the eye. So I think you can find, again, a lot of stuff on YouTube and just by looking up those things on Google. We don't have that many books. There is a great scleral lens book. I'll see if I can get it. 1 second.
Jeez.
So this is the book. It's called Contemporary Scleral Lenses, Theory and Application. And it's by Dr. Melissa Barnett and Lynette Johns. Right now, it's only available in English, but there is so much information. There's information about the eye print, and there's history. There's information about modern technology. So this is a really great book. And also on the Scleral Lens Education Society, it's free to become a member, by the way. And we have a lot of resources, webinars, archived webinars there available, as well as just research and articles available that is free if you become a member. So that's sclerallens.org if you want to check that out.
That's great. Okay, thank you so much, Dr. Kramer. And yeah, I was just mentioning about your recent publication, and somebody just asked me to ask you about the findings, what we were mentioning about scleral lens and IOP. So would you want to give us some thoughts about that? What was your take home?
I think that some patients may have an increase in intraocular pressure, not all of them. I think that it's definitely something you have to take into consideration. If a patient, we don't have any studies on patients with glaucoma and scleral lenses. You know, most of our patients, and the study I did in my office was on regular patients. There were some patients who had an increase in intraocular pressure, but statistically, we didn't find any difference. And that's the important thing. I think that you just have to make sure you follow these patients, continue measuring pressure every year. And if they do have glaucoma, make sure they're being followed. Because as long as you get the pressure under control, you know, you will not have any damage. But obviously, we don't want to be inducing, you know, glaucoma or high pressure. But I don't think that has been shown in studies yet. So just make sure that these patients are being seen regularly, and that you know, we are, you know, watching them closely.
Yeah, I think I did read some part of the paper, and you did comment saying that probably intraocular pressure can be one of the tests which we can include in our aftercare for, especially for scleral lens patients, so that we monitor them. As you were saying, we just monitor them and see if there is any changes, and then take it forward from there.
Yeah.
With that, I think we have taken all questions, and thank you, Dr. Kramer, for doing the session for us once again on Sunday early morning. I would say thank you so much.
Thank you. Thanks for having me.
Most welcome. We do have session planned next weekend. Until then, take care, be safe, and I hope to see you all again next week. Bye bye.
Thank you guys. Bye.
Thank you, Dr. Kramer. Bye bye.